Hey everybody on online. I hope everybody is doing well, getting organized. If you have any problems, you know that you can feel free to see any of us. Today we're going to start talking about the disorders with the red blood cells. Let me just get this into the slideshow for you. Okay. And we're going to start off this section. I want to make sure that everybody knows you need to go by the lab values that are in your med surg book. Those will be the ones that are on the test. It will benefit you to memorize those values for testing purposes. However, remember that every lab is different. So when you get out there in the real world, you'll need to learn the lab values for the place that you're going to be working. And as far as for the pediatrics, if your adult book doesn't have it, you want to go by your pediatric book, okay? So let's get started. This morning we're going to talk about anemias. Anemia is a clinical indicator. It's not a specific disease. It occurs with many health problems and a lot of genetic disorders. It's a reduction in either the number of red blood cells, the amount of hemoglobin or hematocrit that the person has. As far as the patho goes, it diminishes the oxygen carrying capacity of the blood. That's going to cause the reduction in your oxygen that's available to your tissues. There are several types of anemia out there. Look at your med surg book, that table 40-1, which is on page 799, and also look at chart 40-1 on that same page. Okay? Excuse me. Despite the causes or the manifestation, your nursing care is going to be similar in all of these disorders. It can result from dietary problems, genetic disorders, bone marrow disease, or excessive bleeding. Anemia can result in growth retardation due to decreased cellular metabolism, and a lot of times you'll have a coexisting anorexia with this. Racial and ethnic background is very significant in some of these. The anemia related to abnormal hemoglobin levels can be found in your Southeast Asian persons and your African and Mediterranean ancestry persons, which we will see later on when we start talking about thalassemias. A good history of infants and toddlers and even small children can point you to which anemia they are having. Like if you ask the mother about their child and how well they are feeding in the infant, if they're telling you they're taking a very large amount of milk, frequently you'll see that this is an iron deficiency anemia that the child is having, okay? And on these disorders of the red blood cells and the white blood cells, I'm going to combine your pediatric and your med surg book together, okay? Now let's talk about some common manifestations. Skin manifestations, you're going to see pallor of their ears, believe it or not. Their nail beds, you're going to see changes in those. The palmar creases are going to be pale. The conjunctiva are going to be pale, and around the mouth, they're going to feel cold to the touch or cool to the touch, and they're going to have a cold intolerance. They're just not going to be able to stand it. Their nails, as it goes on, can become very brittle and concave in shape. Okay. The cardiovascular manifestations, you're going to see tachycardia, murmurs, and gallops with severe anemia, and you can see some orthostatic hypotension. It can lead, severe anemia leads to a decrease in your oxygen capacity. So it's important for you to assess that patient's energy level and to minimize any excess demands that you're going to have, especially in children. Okay? Know your signs of exertion. or overexertion, which are going to include your tachycardia, dyspnea, shortness of breath, breathlessness, dizziness, lightheadedness, diaphoresis, changes in the color of their skin. Okay. In a fatigued child, you're also going to look for sagging, limp posture, slow and strained movements, and they're going to be unable to tolerate any additional activity. In the infants, what you're going to see also is a difficulty with them sucking. Okay. Respiratory manifestations, you're going to see that dyspnea on exertion and decreased oxygen saturation levels in these patients. Your central nervous system or your neurological manifestations that you're going to see are going to be increased in somnolence and fatigue and headaches. In chronic severe anemia in children, they're frequently going to have delayed sexual maturation in the older child. Okay. Now your nursing manifestations for anemia, you want to treat the underlying cause of that anemia if you can determine it. For instance, if it is because of hemorrhage, of course you're going to treat the hemorrhage. If it's because of iron depletion, you're going to make sure that they're on iron supplements and that their dietary needs are met. Okay? Oral iron, if you're giving that, it should be prescribed in 2 divided doses, and it should be given between meals when there's higher hydrochloric acid in the stomach, because that hydrochloric acid helps to absorb the iron better. Okay? You can give iron with citrus fruits and with juices to help that absorption. If they are receiving an adequate dose of iron, you should be seeing the stool turn that tarry green color. Okay? If they are receiving an iron preparation that is a liquid form, you need to know that this will temporarily stain their teeth. It should be administered through a straw or given with a syringe or a dropper in the back of the throat, okay, or the back of the mouth. You need to have them brush their teeth after administration. This is going to help prevent that discoloration. If they are getting parenteral iron preparations, it's to be given like iron dextran. The injection should be given deep into a large muscle, and you need to use the Z-tracking. Don't massage the area, and make sure that you use that Z-track, because these iron preparations can stain the skin and cause irritation, and actually when I say it stains the skin, it will do like a tattooing that will stay for several months, if not permanent. Okay? If they are getting iron preparations through IV, it must be given very carefully. They're at a high risk for adverse reactions like anaphylaxis with IV administration. Now they have a new preparation out that has not been out for very long. It's furomoxetol, and it is showing some promise to replace the older preparations because it has a lack of that toxicity that you see in the others. Teach your parents that breast milk is very low in iron, so you need to reinforce that they give iron supplements if they're having if they have a breastfed infant. If they are formula fed, then you need to make sure that they know to use a formula that is iron fortified. They also need to make sure, or you need to make sure that they know how the introduction of solid foods should be done at appropriate ages during that first year. Okay? You're also going to minimize their activity to maximize that energy level. You're going to want to make sure that they do a lot of bed rest. You're going to give them replacement fluids, but you want to make sure that you are following a routine, preferably to enhance and maximize the conservation of energy. So you'll want to cluster all of your activities with these children. You'll want to find them things to do, and the adults, things to do in bed that does not expend much energy, such as, you know, reading a book or something like that. Having someone read the book to them. Okay. Like I said, they'll need supplemental iron, and you'll need to go through their diet with them to ensure that they're on appropriate diet and getting sufficient vitamins and minerals and iron. Okay. Now, red blood cell diseases can result from an increased destruction of your red blood cells, like sickle cell anemia or your G6PD deficiency anemia, which is glucose 6-phosphate dehydrogenase deficiency anemia, and your hemolytic anemias. Okay. They can also result from a decreased production of red blood cells, which is going to be like your iron deficiency anemias, your vitamin B12 deficiency anemias, and folic acid deficiency anemias, and your aplastic anemia also falls in here. They can result from an excess of red blood cells and iron, and this is going to be your polycythemia vera and your hereditary hemochromatosis. Okay. And you can have myelodysplastic syndromes, which you will see with anemia, neutropenia, and thrombocytopenias. Okay? We're going to talk about these separately. Now let's talk about the increased destructions, which is your, like I said before, your sickle cell anemia. I have a list here of some of the causes, and you need to think about decreased oxygenation. Okay? It's a genetic disorder. It's autosomal recessive. It results in chronic anemia, pain, disability, organ damage, increased risk of infection, and early death. The severity is going to vary with each patient. It results from the formation of abnormal hemoglobin chains. And let me just stop here and tell you, if you understand the pathophysiology on each one of these, you can then critically think to what manifestations you're going to see and what you're going to do for each one of these. Okay? Normal hemoglobin chains in the pathophysiology will carry a hemoglobin A, which has 2 strains of alpha and 2 strains of beta. Okay? Hemoglobin A should make up about 98 to 99% of normal hemoglobin, and the remaining 1 to 2% is going to be hemoglobin, fetal hemoglobin. Okay. In sickle cell disease, about 40% is going to be made up of hemoglobin S, which is your sickle cell. Okay. It has your standard 2 alpha strains, but the beta strains are abnormal in these, okay? And that is where you get your hemoglobin S. Cells that sickle, they sickle mostly in low oxygen conditions that can cause those abnormal cells to stick together and distort into that sickled shape. Therefore, that's where it gets its name. The change in shape makes them become very hard and rigid, and they clump together. That clumping can cause a vaso-occlusive event, which is, you will see written as VOE. That vaso-occlusive event can lead to tissue hypoxia and cause further sickling of cells. Your vessels can become obstructed, and they will become ischemic, and this is going to damage your organs. Usually these cells will go back to their normal shape once the causing factor of these things that are listed on the screen are removed. The longer these cells stay in that sickled shape, the less likely they are to return to normal shape. Okay? Sickle cells are more fragile, and their lifespan is only like 10 to 20 days instead of the 120 days of a normal red blood cell. So you're going to see hemolytic anemia in these patients. Patients with sickle cell disease also have episodes of what they call crisis. There are several different types of crisis that are listed in your book. Okay, it's a sudden onset of sickling that can happen at any time, and it can be either weekly or yearly. It's just going to depend on your patient. Repeated vaso-occlusive events in large vessels, like I said before, can lead to tissue and organ damage, and small infarct areas that will, they're going to result in scar tissue, and eventually that organ is going to fail. Organs that tend to be affected by sickle cell disease are your spleen, your liver, your heart, kidneys, your brain, joints, bones, and your retinas. Okay? Now, we've talked about sickle cell disease. There is also sickle cell trait. In sickle cell disease, both parents have the hemoglobin S, so the child is going to be 80 to 100% of their cells are going to be sickle cells. Okay? It's also known as SS. Okay? Because of the sickling of the hemoglobin, and they have a double strand of S, so you will see it in their charts as SS sometimes. Look at your pediatric book for good definitions of sickle cell disease and sickle cell trait. Sickle cell trait is also known as AS because you have your hemoglobin A's are normal, and then you have a hemoglobin S with them. In sickle cell trait, the patient carries the sickle cell and can pass it on to their children. One parent has the sickle and the other one has a normal, so that child will have a normal and a sickle. Okay? Let's see. In the United States, about 72,000 have sickle cell disease, and about 1 out of 12 to 15 carry the sickle cell trait. If sickle cell anemia is not diagnosed in early infancy, it's likely to manifest in syndromes during their toddlerhood and preschool years. When they start having infections, usually. Okay? It's usually first diagnosed during a crisis that follows an acute respiratory tract or GI infection. There should be screening done with a sickle turbidity test or SickleDex test on these infants, because it can be performed on the blood with a finger stick, and it yields an accurate results in about 3 minutes. Okay? So, for your patients with sickle cell disease, you want to assess for a history of the disease. Their history is usually long-standing, unless you're dealing with a child, of course. You want to assess for a previous crisis, find out how many times they have a crisis, recent contact with any ill people that they might be having, review their activities for the past 24 hours to try to determine what brought this crisis on, find out what the patient's perceived energy and fatigue levels are, have them grade them. Okay? Find out what led to the crisis, its severity, and how they are usually managed. Activities should include their food and fluid intake, when you're assessing them. Look for changes in their sleep pattern and dyspnea. Have them grade their energy on a scale of 0 as plenty of energy and 10 as being no energy or exhaustion. Pain is a very common symptom. It's the most common symptom that you will see. Cardiovascular changes are going to include fatigue or weakness. They're going to have murmurs. You can have a presence of a S3, and you can see that jugular vein distension. In males, you can also see penile erections due to vascular engorgement of the erectile tissue. This can be very painful, and they usually cannot urinate when this happens, okay? Skin changes, like I said before, you're going to see pallor or cyanosis due to poor gas exchange in these patients. Look at their lips, look at their tongue, their nail bed, their conjunctiva, the palms and soles of their feet, and you need to assess these every 8 hours. You need to also assess for jaundice, which can occur with a lot of red blood cell destruction because of that release of bilirubin. You need to look at the roof of the mouth in the darker skinned persons. Monitor for ulceration formation in their lower extremities due to, it will show you a decreased perfusion. Okay, abdominal changes, you're going to watch that liver and that spleen, watch for enlargement of those. Abdominal pain can be diffuse and steady, and it can spread to their back and their legs. Their liver and their spleen, when you're assessing them, they might be firm, they might be enlarged and nodular feeling and texture, especially in the late stages. Remember, be very careful with that spleen because it is very fragile and it can rupture very easily. Kidneys and urinary changes, you will see we're going to be due to noxious damage to the nephrons. This damage is going to decrease the filtration and reabsorption rate. Their urine is going to contain protein, and a lot of times their urine is going to be very concentrated. Okay, musculoskeletal changes that you're going to see are going to be due to occlusion of the vessels in the arms and the legs. Their joints can be damaged. You need to assess their joints for swelling and temperature and color differences. Monitor their range of motion. All right. Your central nervous system changes can lead. These changes can lead to seizures if they're in a crisis. And in severe manifestations, they can also have a stroke. You want to assess for pronator drift, okay, like you learned from Miss Enlows. Check their grips, check their gait and their coordination. Behavior changes are an early manifestation for these patients. You need to ask the family about any mental status changes or behaviors that they've noted recently. This is going to be due to that lack of oxygenation, so yes, that would be an early sign. You want to assess their life status, see if there's anything that contributes to the crisis, and ensure that the patient has sufficient support system and uses their coping patterns that are effective for them. Stress and anxiety just what's the word I'm looking for? Enhance their crises and cause it to become more severe. Diagnosis of sickle cell disease is usually based on the percentage of that hemoglobin S that's found in electrophoresis. This is your laboratory and diagnostic assessments. Your hematocrit is going to be low because of the shortened lifespan of the red blood cells. The number of red blood cells, like I said before, the longer the crisis goes on, the more permanent that sickling is going to be. Okay. You're going to have a reticulocyte count that is going to be elevated, which is going to indicate long-standing anemia to you. Okay, and what is your reticulocyte count? Remember from our last one, it is the immature red blood cells that are released. Okay, they're released early before they mature. Bilirubin levels are going to be elevated because the damaged cells are releasing that bilirubin and iron. Your white blood cells will be elevated due to chronic inflammation caused by tissue hypoxia and the ischemia. Okay. Diagnostics will show changes due to the poor oxygenation and perfusion of the bones in the joints. Your patient's ECG is going to show changes related to the areas of the heart that are damaged. An echocardiogram may show cardiomyopathy. They'll have a low ejection fraction, which is going to indicate to you that they have a decreased cardiac output. So what are some of the interventions that we can do for these people? Okay, number one, you need to manage the pain, all right, and provide oxygen for these patients. Management of pain is done with morphine and Dilaudid and your doxia or hydroxyurea, okay? The aim of therapy is to prevent the sickling phenomenon, which is responsible for the pathological siliqui that you will see. It should be treated as a medical emergency when they are in sickle cell crisis. You want them to rest and minimize their energy expenditure to improve that oxygenation. You're going to hydrate them through oral and IV therapy and electrolyte replacement because that hypoxia results in metabolic acidosis, which is just going to promote more sickling. Do analgesics for the severe pain with vasocclusion, and they may be on this for a few days. Okay, blood replacement to treat the anemia and to reduce the viscosity of those sickled cells might be done, and antibiotic therapy to treat infections that are existing that might be causing this sickle cell crisis. Okay, pain management is usually started with a 48-hour IV analgesic with a PCA pump of morphine or Dilaudid. PRNs are not usually provided because they don't provide an adequate relief. They need that steady relief of pain. Moderate pain can be managed with your PO opioids and NSAIDs. The hydroxyurea can be given to reduce the number of sickling and pain episodes, but it stimulates the fetal hemoglobin production. Okay. Remember that hydroxyurea is also associated with the increased incidence of leukemia and bone marrow suppression, so they don't want to give this as often. Okay, we want to stop that crisis before it comes to this point. Your hydration, you do both oral and IV. It helps reduce the duration of those pain episodes, so encourage them to drink as much as possible. Juices and water. You want to watch about cold, because it can cause them, if they can stand something at a tepid room temperature, it's better for them to drink that than to drink cold. Okay? Remember, these patients are hypertonic, so they need to be given a hypotonic solution at about 250 milliliters per hour for 4 hours, or until their blood has a normal osmolarity range, and then it should be decreased to 125 milliliters per hour if they cannot keep themselves hydrated. Okay? Complementary therapies that you're going to be seeing done is to keep them warm, keep their room warm, provide them with distraction and relaxation techniques. Okay? Remember, keep them still and quiet. Position changes and support of painful areas are another complementary therapy that you can do. Also, warm soaks or compresses can help with the pain in those joints. They're going to be at high risk for infection due to the compromise of their spleen. If that patient has fever, they need an extensive diagnostic testing to rule out sepsis. So you'll see them having CBCs with differentials done. They'll have blood cultures done. They'll do reticulocyte counts, urine cultures, and chest x-rays on these patients. Okay, they're going to be started on antibiotics. They're going to be a broad spectrum until it is determined what type of bacteria or viral infection is going on. You need to think ahead and protect these patients that are in crisis of infections. In other words, good, meticulous hand washing and strict aseptic technique for all invasive procedures is a must for them. You need to inspect their mouth for lesions, listen to their lungs every 8 hours for those crackles, wheezes, and any reduction in breath sound. You want to inspect their urine and monitor their vital signs at least every 4 hours. Continued occlusion of these blood vessels are going to lead to that vaso-occlusive episodes, and it's going to put them at an increased risk for multiple organ obstruction. Okay, monitor them for adequate perfusion in all their body areas, not just in their arms and legs, but you need to monitor, the kidneys and everything else too. You want to help remove any restrictive clothing from these patients and instruct them to avoid flexing their knees and hips as much as possible. These can cause an obstruction as well in that blood flow. Help them to maintain that hydration status. That's going to help prevent that sickling. They should have an intake of at least 200 milliliters per hour. You want to put them on oxygen therapy, and it needs to be nebulized to prevent dehydration. Okay? They may require a transfusion of red blood cells to increase their hemoglobin A levels and to dilute that hemoglobin S. So you're going to need to monitor them closely to prevent an iron overload in these patients. Some are going to receive hematopoietic stem cell transplants to permanently correct that hemoglobin problem, especially the ones that go through multiple vascular occlusive crises. Okay? The crises become worse at time, and a true remission is rare in these patients. Your care needs to focus on teaching the patient and the family how to prevent crisis and complications. Okay, there's a good chart on page 803 to help you with this teaching. Teach the patient what activities to avoid and how to recognize and reduce stress in their life. Teach them that they need to start interventions early and maintain their hydration status. The patient and the family need to have counseling about hereditary aspects of sickle cell disease, birth control information, and pregnancy options also. Okay. Now let's move on to beta thalassemia or Cooley's anemia, and this is not in your med-surg book. You will find this in your pediatrics book. Okay. It occurs in four forms: minor, thalassemia minor, thalassemia trait, thalassemia intermediate, and thalassemia major, which is the Cooley's anemia. Normal postnatal hemoglobin B is composed of 2 alphas and 2 betas, like I said before. In B thalassemia, there is a partial or complete deficiency in the synthesis of the beta chains of the hemoglobin B. So there's a compensatory increase in the synthesis of alpha chains and gamma chains production. The gamma chains usually are inactivated, but in the case of thalassemia, they remain activated and they cause a defective hemoglobin formation. The polypeptides are very unstable, and when it disintegrates, it damages the red blood cells, causing severe anemia. stimulates an overabundance of erythrocytes to form. Unless that bone marrow is suppressed by a transfusion, the patients are going to have an excessive iron from hemolysis and also from supplemental red blood cells from the transfusions and rapid destruction of the defective cells, which is going to cause it to be stored in the organs. Okay. This one gives you a picture of someone that has severe thalassemia. The anemia, before diagnosis, you're going to see pallor, unexplained fever, poor feeding. They're going to have an enlarged spleen and enlarged liver. They'll have signs of chronic hypoxia, such as headaches, procardial pain, and bone pain. They're going to have decreased exercise tolerance, listlessness, and anorexia. Other features that you're going to see are they're going to be small in stature. They're going to have a delayed sexual maturation, and they're going to have bronze freckling in their complexion, and this is caused by the release of the iron. Excuse me. Bone changes in the older children, if they're untreated, are going to include an enlarged head, predominant forehead with that partial bossing that you can see on this child's forehead. They're going to have a predominant malar emesis. They're going to have a flat, depressed bridge to their nose, as this child has. They're going to have an enlarged maxilla. They're going to have protrusion of the lips and the upper incisors, and eventually they're going to form a malocclusion. Okay, and they're going to have a generalized osteoporosis. Transfusions are the foundation for medical management in these children, and the goal is to maintain a hemoglobin of 9.5 grams per deciliter. They might require transfusions as often as every 3 to 5 weeks. It's going to depend on the severity of their case. The therapy improved physical and psychological well-being because of their ability to participate in normal activities and decrease that cardiomegaly and hepatosplenomegaly that these patients will have. They'll have fewer bone changes with these transfusions, normal to near normal growth and development until puberty, and they'll have fewer infections. So you'll need to teach the patient and the family, the child and the family, how important these transfusions are to them. Some children are going to require a splenectomy to decrease the disabling effects of abdominal pressure that they're going to have and increase the lifespan of those supplemental red blood cells that you're transfusing into them. They're going to need to guard against overwhelming infections. The patients and the families need to be taught to understand the need to notify their healthcare professionals if they have a fever of 101.3 or greater, because they're at an increased risk for sepsis. Okay. Nursing care objectives are to promote compliance with their transfusions and chitillation therapy, which the chitillation therapy is to remove the excess iron that these patients will have. Assist the child in coping with anxiety-provoking treatments, because that they can become very anxious when they're having to have so many transfusions, and the effects of the illness. You need to foster this child's and this family's adjustment to the chronic illness, and to observe for compliance with the multiple blood transfusions. These are very important for these children. Okay, now we're going to jump back to our Med-Surg book and talk about the increased destruction anemias again. with your G6PD deficiency anemia. And I've listed here your causes that you will see this. It is an X-linked recessive disorder with most severe expression in males and mild partial expression in your carrier females. The G6PD stimulates glucose metabolism into ATP. These patients have a decrease in the amount of the G6PD on the cells, which causes it to break more easily during exposure to some drugs and other toxins. This decreases your cell age or the life of your cell. After exposure to the precipitating cause, the red blood cells begin to break, and this can last for 7 to 12 days. During an acute phase, anemia and jaundice will develop in these patients. Okay? And like I said, we have gone over a lot of interventions already that you will see used in all of these. In your G6PD interventions, prevention, males, they need to be tested before giving them any drugs that are known to cause problems, like your sulfonamides, aspirin, quinine derivatives, chloramphenicol, dapsone, and high doses of vitamin C and thiazide diuretics. Okay, so you need to test these patients to make sure that it is not going to throw them into crisis. Okay, also exposure to benzene and other toxins. For these patients, you need to keep them hydrated. Hydration is important to prevent the debris and hemoglobin from collecting in their kidney tubules. Osmotic diuretics can help to prevent occlusion of those kidney tubules. Transfusions are done if their anemia is present and their kidney function is normal. Otherwise, they will not be transfused. Okay? So, now let's talk about increased destruction in your immunohemolytic anemias. I'm sorry, I can't talk this morning. The most common is your autoimmune hemolytic anemias. The pathology is an abnormal immunity that results in excessive destruction of red blood cell membranes with an accelerated erythropoiesis. Okay? Acquired results for an increased red blood cell destruction from trauma, viral infections, malaria, exposure to chemicals and drugs, and your autoimmune reactions. Red blood cells are unknown to the person's body, and this is your patho that's going on. They're seen as foreign or non-self by the immune system, and they are attacked and destroyed. The warm antibodies are when the IgG is in excess, okay? And they are more active in warmth and can be triggered by drugs, chemicals, and autoimmune problems. Okay? The higher the temperature outside, the more likely they are to have an episode. The cold antibodies are your IgMs, and they are more active in low temperatures. The problems often occur like Raynaud's like syndromes in the arteries, in the hands, and the feet. They constrict profoundly in response to cold temperatures and stress. The management is going to depend on the severity. Steroid therapy is going to suppress the immunity and is temporarily effective only. So most will have to have a splenectomy and more intense immunosuppressive therapy or even chemotherapy. They'll have plasma exchange with antibodies removed, and this is effective for patients who do not respond to the chemotherapy. Okay? Now let's talk about the anemias that are caused by a decreased production of red blood cells, like your iron deficiency. Iron deficiency is your most common form in the world, especially among women. It results from blood loss, poor GI absorption of iron and inadequate diet. The red blood cells are microcytic, which means they are light red, and they have mild symptoms of anemia like weakness, pallor, fatigue, reduced exercise tolerance, and fissures in the corners of their mouth. Their serum ferritin values are less than 10 nanograms per milliliter. You want to evaluate them for abnormal bleeding, especially from the GI tract. Okay, see where that blood's coming from. See if you can find it. With mild deficiencies, you're going to give them an oral iron supplement and instruct them to take it between meals, remember, for better absorption and less GI distress. Okay, increase for moderate deficiency, the oral intake from food like red meats, organ meats, egg yolks, kidney beans, leafy green vegetables, and raisins. For the severe anemics, you're going to have iron solutions like iron dextran and the furomoxetol that I told you about earlier, and they're going to be given IV or IM. Okay. Now, another one is your decreased production in red blood cells is your vitamin B12 deficiency or pernicious anemia. Okay, you're going to see causes of this as your vegan diets, and I have a list of them here for you. It's also called pernicious anemia, like I said, because of the deficiency of intrinsic factor that's needed to absorb your vitamin B12. Okay. It is caused by a failed activation of enzymes to move folic acid into the precursor red blood cells, so cell division and growth cannot occur. They undergo improper DNA synthesis, and they have an increase in size. All right, the cells are large in size, so they're megablastic and they're macrocytic. So what is macrocytic? Do you remember? Okay, now they are so big that only a few of these can be released from the marrow at a time. That's why you see a decrease in the red blood cell count. All right. The next slide shows you your signs and symptoms. They develop slowly. Okay. Your book, your MedSurg book, has a very good picture of this glottitis. It's a smooth, beefy red tongue. Okay, and that is one good sign that it is a B12 deficiency in your patients. So yes, you'll have them stick out their tongue and look at it. Fatigue, weakness, weight loss, paresthesia of the hands and feet. They're going to have poor balance. Okay. As far as the interventions go for B12, you want to increase their food intake of B12 enriched foods. These can include, like I said before, animal proteins, fish, eggs, nuts, dairy products, dried beans, citrus fruits, and leafy green vegetables. The patients with pernicious anemia are given weekly injections to begin with of B12, and then they go to monthly, and they may have to have these for the rest of their life. There are some oral supplements of B12. The sublingual works real well, and then they have a nasal spray preparation that can be given to maintain a normal level after injections in most of these patients. They will usually start out with the injections. Okay. It's going to depend on the severity of the anemia. A lot of them, if they are just B12 deficient to a mild to moderate, they will give them one injection and then start them out on the orals. Otherwise, they're gonna do the once a week for a month and then monthly after that. Okay. Our next decrease is your folic acid deficiency. Here are some of the causes. Your poor nutrition, Crohn's disease, anticonvulsants can cause folic acid deficiency, and oral contraceptives. Okay, manifestations are going to be similar to your vitamin B12 deficiency. except you're going to have nervous system function involvement with this. You need to identify high-risk patients, like your older debilitated patients with alcoholism. Okay, so you're going to have to do an assessment to find out their alcohol intake. Also at risk are those with malnutrition and those with the increased need of folic acid, like your pregnant mothers. Okay, prevention is achieved by maintaining a diet that's high in folic acid and B12. Management is done with scheduled folic acid replacement therapy in these patients. All right. Now, decreased production in red blood cells, your aplastic anemia. I've listed here the causes, like injury of immature precursor cells, leukopenia and thrombocytopenia and pancytopenia. It can have a slower or rapid onset. Long-term exposure to toxic agents, radiation, infections is most common hereditary form is your Fanconi's anemia. Okay, deficiency in the red blood cells is due to the marrow not producing the cells. The patients are going to manifest with a severe anemia. Their CBCs are going to show macrocytic anemia, leukopenia, and thrombocytopenia. Bone marrow biopsy will show replacement of cell-forming marrow with fat. Okay, an infection is common. Acquired aplastic anemia is classified as either severe acquired or moderate acquired. Severe carries a poor prognosis and follows a more rapidly fatal course than the primary type does. Okay. Interventions therapy is directed at restoring function to the marrow and involves two main approaches: immunosuppressive therapy to remove the presumed immunologic function that prolonged aplasia, and your other one is replacement of the bone marrow through transplantation. Bone marrow transplant is the treatment of choice for the severe aplastic anemia when a suitable donor exists. You're going to have anti-lymphocyte globulin, the ALG, and anti-hemocyte globulin, ATG, are going to be the primary drugs to treat the aplastic anemia. And they need to be given through a central line and monitored very vigilantly to prevent any exacerbation. Okay? If you can't get a central line, meticulous care of a venous access is essential because these patients are susceptible to infection. All right? Your ATG will suppress the T cell dependent autoimmune responses, so your stem cell transplant should be considered early in the course of the disease if you can find a compatible donor. Unnecessary transfusions will increase the likelihood of a transfusion reaction to platelets and decrease the lifespan of those transfused cells. Okay, in your bone marrow transplant is a successful treatment for aplastic anemia, but its cost and availability and complications have limited its use. Drugs like prednisone and anti-hemocyte globulin, the ATG, cytosporin A, have resulted in partial or complete remissions in these patients. Dazetamab has also improved both blood counts and transfusion and decreased transfusion requirements for these patients. A splenectomy may be needed to prevent destruction or suppress the development. Let me back up here. A splenectomy may be needed to prevent destruction of or suppressing the development of normal red blood cells in these patients, okay? Disorders of excessive red blood cells or iron in the patients. The main disease you're going to see is polycythemia vera. Hallmarks are a massive production of red blood cells, excessive leukocyte production, and excessive production of platelets in these patients. I have listed here your signs and symptoms that you will see. Okay, the amount of red blood cells is going to be greater than normal. It leads to their blood being thicker than normal, and the condition is chronic. In polycythemia vera, the blood and hemoglobin and hematocrit levels and the red blood cell counts are going to be very elevated. This is a form of cancer with these three hallmarks that you see. These patients have an extreme hypercellularity in the peripheral blood. Even though the number of red blood cells is greatly increased, their oxygen carrying capacity is impaired, and this causes poor gas exchange and hypoxia in these patients. Polycythemia vera is a malignant disease that progresses in severity over time. If untreated, few people live longer than 2 years after their diagnosis. Okay, the main management is repeated phlebotomy with apheresis about 2 to 5 times a week. You can see that they spend an exorbitant amount of time in the hospital or doctor's office. The patient may live for 10 to 15 years if they do have these treatments, or longer than that even. You need to encourage increased hydration in them to promote venous return and to help prevent clot formations. Okay. Their therapy will also include anticoagulants. Aggressive IV chemotherapy is not recommended because it increases the risk for the leukopenia in these patients. Aspirin therapy can be used to decrease the clot formation, and your hydroxyurea is used for severe manifestations of the disease. Interferon alpha therapy is also shown benefits in controlling the red blood cell production. You need to look at the chart on page 805 for other care for these patients. All right. Next, we're going to go into the hereditary hemochromatosis. Here's your signs and symptoms listed for you. It's an autosomal recessive disorder with a mutation in both alleles of the HFE gene, causing an increased intestinal absorption of dietary iron. The excessive iron is deposited in tissue and organs like your liver, your spleen, your heart, your joints, your skin, and your pancreas. These deposits will damage the organs and lead to organ failure. It's usually diagnosed on a basis of clinical manifestations and altered iron levels. Phlebotomy and removal of about 500 milliliters of blood at a time occurring as often as twice weekly at first, is performed to reduce the overall iron load in the blood. You want the blood ferritin level less than 9 to 50 micrograms per liter. Then reduce the phlebotomy when you reach that level to once every 2 to 4 months for maintenance in these patients. Okay. The last disorder of excessive red blood cells or iron is your myelodysplastic syndrome, or MDS. You'll have several types. Anemia is going to be your red blood cells, your neutropenia is your white blood cells, thrombocytopenia is your platelets, and pancytopenia is all counts that you're going to see elevated. Risk factors are your aging, chemical exposure, tobacco smoke, and excessive radiation and chemo drugs. This is a group of disorders that's caused by the formation of abnormal cells in the bone marrow, which are quickly destroyed after release into the bloodstream. The exact cause is not really understood. Diagnosis is made by examination of the chromosomes and the genes within the chromosomes of the bone marrow cells. Okay, Peripheral blood smears are used to assess the levels of cell maturation and the proportions of abnormal cells. The only potentially curative treatment is an allogenic hematopoietic stem cell transplant. So in other words, they're going to transplant all stem cells. They'll eradicate every one of them in the body first. It might not be an option because of the advancement in age in some of these patients. For low-risk anti-tumor immunomodulatory agents like your lenalidomide are used for dysplastic cells to eradicate them. For intermediate risk and high risk, they're going to use azacitidine and decitabine. Okay. They take 3 to 6 months to achieve a clinical response, and the patients will need a large amount of supportive care. The supportive care for these patients is going to include transfusions of blood and platelets, erythropoiesis stimulating agents like your epitin alpha, Procrit for the other name of it, or your DABA protein alpha can be given. Alright, and that's the end of this one. We will come back in a little while and do our white blood cells. Again, as usual, if you have any questions or concerns, please feel free to send me a message, preferably a message in Blackboard instead of in my campus email. I do check my campus email, but I only check it about once a day. So if you want me to check more often, you will want to hit me in the course. Okay? Thanks again. Bye.